Welcome to the ABBRUPT site initiation training video. ABBRUPT is a randomized controlled trial to investigate the clinical and cost-effectiveness of amiodarone versus beta blockade for patients with new-onset atrial fibrillation, or a new episode of atrial fibrillation, whilst in ICU. We are working with protocol version 4 dated the 20th of January 2025. The chief investigator is Dr. Dhruv Parekh and the deputy chief investigator is Professor Ingeborg Welters. The trial manager is Lisa Holden, the data manager is Kate Brailsford, the sponsor is the University of Birmingham and the funder is the HTA. During this site initiation training we will discuss the background to the trial and the trial objectives, the study design, data management, safety reporting and compliance and conduct. Firstly, let's look at the background to the trial and the trial objectives. Atrial fibrillation is a common irregularity of the rhythm of the heart. New-onset AF, which is AF never previously diagnosed in a patient, occurs in approximately 5 to 26% of intensive care unit patients depending on age, sex, obesity, comorbidities and the reason for ICU admission. Retrospective studies suggest that patients with NOAF who are treated with amiodarone have worse outcomes, increased risk of stroke, myocardial events and death, than those treated with beta blockade. The risk of bias is that sicker patients are treated with amiodarone and so a prospective randomized trial is necessary. ABBRUPT is a comparison of amiodarone and beta blockade to establish which management of new-onset AF, or a new episode of AF, is best to avoid harm and achieve optimal outcomes in patients in ICU. ICU survivorship leads to chronic ill health, morbidity and mortality. AF is also associated with significant ongoing costs in terms of disability, care and treatments. ICU clinicians need to understand the best treatments to apply at the time of critical illness to optimize good survivorship, that is, a long and healthy post-ICU recovery. Now, let's look at the study design. These are the two interventions used in the ABBRUPT trial. Amiodarone is the intervention. The treating clinician can choose the route and the duration. Beta blocker is the comparator. The treating clinician is able to choose which beta blocker to use, the dose and the route. The primary outcome is 90-day mortality. There are also a number of secondary outcomes, some relating to safety and health economics. The inclusion criteria is adult patients aged 16 years or over. Patients being monitored in an area of higher care with the ability to deliver the interventions. Patients who develop new-onset AF or a new episode of AF during their acute illness, either in A&E, deterioration on the ward or after surgery, where there is a clinical indication to treat with amiodarone or beta blockers, and where usual electrolyte management with potassium and magnesium has taken place. The exclusion criteria is patients receiving treatment with anticoagulants or antiarrhythmics for the treatment of AF before the current hospital admission. Please note that anticoagulants or antiarrhythmics used for any other purpose can be included. Patients with current concomitant medication that are contraindicated with amiodarone or beta blockers. Patients with a serum potassium of less than 4 millimoles per liter. Patients who have undergone cardiac surgery during their current hospital admission. Patients who have been diagnosed with thyrotoxicosis. Patients who are going to be withdrawn from life support therapy within 24 hours. Patients with any other known contraindication or known sensitivity to amiodarone or beta blockers. Patients who are known to be pregnant or breastfeeding. Patients will initially be identified with new-onset AF, or a new episode of AF, by their existing clinical care team. As recruitment can occur at any time of the day or night, sites should make efforts to ensure that a system exists whereby patients may be recruited and randomized at any time of the day and any day of the week. Eligibility must be confirmed by a medically qualified member of the research team. The person confirming eligibility must be delegated the duty on the delegation log and have completed the ABBRUPT training. The exception to this is where the PI has delegated the training link to members of the team who will be confirming eligibility and randomizing only. Targeted GCP training is available for some roles within the trial, which will provide a brief overview of GCP. The PI and senior research nurse should always have full GCP training though. Screening logs of all eligible patients or legal representatives that are approached will be completed electronically via REDCap Annex. The latest version of the informed consent form must be completed by the participant or their legal representative. ICFs are paper-based and a copy must be given to the participant or legal representative, a copy sent to BCTU or uploaded into the REDCap database, and a copy filed in the participant's medical notes. The original ICF must be placed in the investigator site file. As we are using deferred consent, a participant can be recruited without consent being in place, although we ask that some form of consent is in place within 72 hours of randomization. As this is an emergency care trial, it would be clinically unjustifiable to delay treatment until informed consent can be obtained from a legal representative. If a personal legal representative cannot be identified, we ask the local research team to identify a professional legal representative who is independent of the trial, usually the doctor primarily responsible for the medical treatment of the patient. The legal representative information sheet should be provided, and they should be given time to consider the information and have any questions answered before being asked if they are willing to provide consent on behalf of the patient. If face-to-face consent is not possible, remote written consent may be undertaken using the record of telephone declaration form. This will be initialed by the researcher in the presence of a witness and a copy either emailed or posted to the legal representative. An assessment will be made at site to determine whether the patient has regained capacity and is able to consent for themselves. Where this is found to be the case, the patient will be given the participant information sheet to read, or have it read to them. Once the patient has had time to read the PIS and ask, and have answered, any questions, they will be asked if they are willing to give consent to continue participating in the trial. The correct ABBRUPT informed consent form should be used with the corresponding ABBRUPT information sheet. For example, where a participant information sheet is issued to the patient, the participant ICF should be completed. This is an example of the participant informed consent form. Participant consent is ongoing consent to continue in the trial. Where a legal representative information sheet is issued, a legal representative ICF should be completed. If face-to-face consent is not possible, a record of telephone declaration can be completed in the presence of a witness. This is an example of the legal representative consent form. And this is an example of the record of telephone declaration form. Informed consent and confirmation that the patient is still willing to participate in the trial should always be documented in the patient's notes. ABBRUPT screening logs will be completed monthly and captured in the REDCap Annex database. REDCap Annex is a separate system to the REDCap trial data database with separate logins. This is what the screening log looks like. It has drop-down lists for reasons why the patient was not eligible or recruited. Randomization will be provided by a secure online randomization system held at BCTU. Users will be given unique usernames and will set their own password. Usernames and logins are not to be shared. A drop-down list will be built into the database so only those delegated the duty can perform certain tasks. The system will be available 24 hours a day, 7 days a week. Please see the ABBRUPT CRF completion guidelines document in your investigator site file for further REDCap user guidance. Randomization may begin once eligibility has been confirmed. If data items are missing, randomization will be suspended but can be restarted once all the information is available. Once fully completed, please then mark the randomization form as complete. With the patient's or legal representative's consent, inform the patient's GP of their participation in the trial using the ABBRUPT GP letter. If you are unable to randomize for whatever reason, please contact the ABBRUPT trial office immediately. This is a screenshot of the REDCap database for randomization and data entry. When you log in to the database, select Add, Edit Records, then select Add New Record and then select Create a New Record. There are more detailed guidelines available in the ABBRUPT CRF Completion Guidelines document for REDCap user guidance. This is a screenshot of the randomization form. Note the trial number is in the top left-hand corner. Please enter the trial number onto the ICF. There will be a drop-down list of people who can confirm eligibility based on roles delegated on the delegation log. Once all the information has been entered, mark the form as complete and select Save and Stay from the drop-down menu for the randomized allocation. There are 3 options for patient withdrawal. 1. The patient no longer wishes to receive the trial intervention. 2. The participant does not wish to attend trial visits. Or 3. The participant is not willing to be followed up in any way. The researcher or legal representative can also withdraw the patient from the trial and/or trial intervention. Please detail the changes in levels of participant in the patient's medical notes and also complete a change of status form. All patients will be included in the analysis on the intention to treat basis up to the end point of the trial or to the point where total consent was withdrawn. We will now look at data handling. Source data will consist of patient data, which is data obtained using the hospital health data system. The participant's medical notes will be the source. Patient-reported outcomes, obtained from the participant via interview with site research staff and transcribed onto CRFs, which are the source data. Clinical event data. The original clinical annotation is the source document. For example, electronic or paper participant medical notes. Laboratory results, the original lab report, which may be electronic. Health economic data, where a patient expresses a wish to withdraw, the conversation must be recorded in the patient's medical notes. This will be the source data. Withdrawal, patient's expression of desire to withdraw must be documented in the medical notes. This will be the source data. Recruitment, the original record of the randomization is the source data. With the exception of SAE and pregnancy forms, which are paper-based, all CRFs are completed electronically via REDCap by site staff. CRFs are considered complete once all data fields are completed unambiguously or the data is marked as unobtainable. Validation checks have been built into the REDCap database. CRFs should be completed as soon as they become due. Please mark the CRF as complete once all data has been entered. As previously mentioned, once all data has been entered, select Complete from the drop-down list as shown here. This is a screenshot of the CRF homepage for participant 10015. The record ID shows you which record you're in. The red dot indicates that the baseline form is incomplete. All other forms are shown as incomplete or no data has been saved. The 5 upcoming calendar events will show you when each daily assessment is due. This is an example of the baseline form. The information on this form will capture the 24 hours prior to randomization. Once all information has been entered, select Complete at the bottom of the form. As previously mentioned, all CRFs are entered directly onto the REDCap database with the exception of SAE forms and pregnancy forms. SAE forms and pregnancy forms should be emailed to the ABBRUPT mailbox as soon as possible and within 24 hours of site knowing of the event. Any queries generated to address missing or ambiguous data on SAE and pregnancy forms will be emailed to research staff at site. The ABBRUPT Trials team will review the data entered into REDCap by site staff. Missing and ambiguous data will be queried using data clarification queries within REDCap. Data queries should be resolved by site staff that have been delegated this role on the delegation log. Once all queries have been resolved, the form will be locked by the ABBRUPT trials team. To resolve queries that the trials team have generated, select Resolve Issues in the Applications tab on the left-hand side. This will open the data resolution workflow. Correct the issue and complete the data query. The trial team are unable to add, amend, or remove data on behalf of sites. The calendar in the Applications tab details when follow-up forms are due. This is the calendar which shows all the forms that are due and when. Data security will be maintained at all times. This will be through physical security measures, limiting access control, through network security measures, system design and management, operational processes, data processing, data protection registration and system audits. We will now look at safety reporting in ABBRUPT. The definition of a serious adverse event is any event, adverse reaction or unexpected adverse reaction that results in death, is life-threatening, requires hospitalization or prolongation of existing hospitalization, results in persistent or significant disability or incapacity or consists of a congenital abnormality or birth defect. All adverse events must be recorded in the participant's medical notes. Adverse events and expected serious adverse events are recorded on the follow-up CRFs. Unexpected SAEs that require expedited reporting will be recorded on a serious adverse event form and securely emailed to the ABBRUPT trials team within 24 hours of site knowing of the event. BCTU will report SAEs to the DMC and REC as appropriate. There are some SAEs that do not require expedited reporting. These are hospital admissions that are less than 24 hours and pre-planned hospitalization. The frequency of SAEs in this patient population may be high. Many of these SAEs will be anticipated and as such have been protocol defined as expected. These do not need to be reported to the ABBRUPT trial office on a SAE form. They should instead be reported on the follow-up CRFs and documented in the patient's medical notes. In summary, SAEs that do require expedited reporting on a SAE form are hospitalization for SAEs not listed as expected in the protocol, death, if not related to the underlying cause of ICU admission and pregnancy, if applicable. Those outcomes that require an expedited SAE to be completed are detailed on the pregnancy notification form. So for SAEs requiring expedited reporting, please document in the patient's medical notes and complete a SAE form and email to the ABBRUPT trial office within 24 hours. So again, if the event is serious but listed as expected in the protocol, please report on the follow-up CRFs. If the event is serious and not listed in the protocol as expected, complete a SAE form and email to the ABBRUPT trial office within 24 hours of knowing of the event. Pregnancy is very unlikely in this patient population. As pregnancy is an exclusion criteria, women of childbearing age should be tested for pregnancy as part of routine care upon admission to ICU. However, if this is not performed, we will require evidence of how you intend to monitor and/or confirm this. If a participant does become pregnant between randomization and the end of the follow-up period, the patient must be withdrawn, a pregnancy notification form completed and if applicable, a SAE form completed. The sponsor is responsible for notifying the REC of any serious breach of the conditions and principles of GCP in connection with the trial. Sites must notify the ABBRUPT trial office of any suspected trial-related serious breach of GCP and/or the trial protocol as soon as it becomes aware of them. Sites must provide sufficient information to report the breach and engage with undertaking any CAPA. Sites may be suspended from further recruitment in the event of serious and persistent non-compliance with the protocol and/or GCP, and/or poor recruitment. If you are ever uncertain as to whether or how an adverse event or potential serious breach needs to be reported, please contact the ABBRUPT trial office for assistance. Now we will talk about compliance and trial conduct. ABBRUPT will be conducted in compliance with the approved protocol, the Principles of Good Clinical Practice (GCP), as set out in the UK Policy Framework for Health and Social Care Research. Data Protection Act 2018. The Mental Capacity Act 2005. The PI's responsibilities include reading the approved protocol and signing and returning the PI signature page, adhering to the approved protocol, and being responsible for enrolling only those patients that meet the eligibility criteria. The ABBRUPT trial is registered with the Associate PI scheme. This is a unique NIHR development opportunity aimed at any healthcare professional who would like to get more involved in research as part of their career path. It is a 6-month in-work training mentorship providing practical experience. The local PI will guide and assist the Associate PI in understanding research and fulfill the requirements outlined in Associate PI checklist. The ISF should always be kept up to date. The ISF will be monitored by study staff or a representative of the sponsor. The original consent forms, completed paper CRFs, completed SAE forms and any file notes must be kept in your ISF. Now let's look at monitoring in ABBRUPT. Central monitoring will be carried out on all ICFs and CRFs to check for compliance with the protocol, data consistency and any missing data. Sites will be sent data queries requesting missing or clarification of ambiguous, inconsistent data. On-site monitoring will be assessed on an individual and risk-proportionate approach and might be triggered by poor CRF returns, poor quality data, repeated issues with randomization, ineligible patients being randomized, repeated issues with consent forms, not completed correctly, or a significant amount of missing data, etc. End of trial and archiving. The end of trial will be 6 months after the date of the last data capture, including resolution of data queries. Once all close-down activities have been completed, the sponsor will authorize sites to archive their ISF. The ISF will be archived according to local policy and stored securely and confidentially for at least 25 years. There is a payment of £500 within the site agreement to pay for archiving costs. These are the ABBRUPT trial office contact details. The ABBRUPT website will be kept up to date with the current protocol and patient-facing forms. That is the end of the site initiation training video. Now, please finish completing your electronic training record. Please upload a copy of your signed CV and GCP certificate if you have not already done so. Ensure you proceed to the final page, sign your certificate and click Submit to fully document completion of the training. Please print your certificate and store it in your ISF. Please also complete the delegation log. If your site is not yet open to recruitment, you will be invited to a live virtual Q&A meeting with ABBRUPT Trials Office to discuss any questions or queries you may have.